96% of all problems in revenue cycle are not caused by your biller. I don't live in the world of just what I think and accusation. I live in the world of data and what I know. And the right data tells you what you need to know to understand how things really work. It's just super important that you have baseline data. You can at least start to understand what baseline normal is for you. You want to reduce complexities. You want to create a condition where this is as simple as it can be so the outcomes are consistent. And it's the disconnect between time supply and time demand that creates outcomes that are suboptimal. And what the AR audits allow us to do is understand the complexities and the problems from a little bit different angle. The AR audit is absolutely critical to do.
Robert Kowalick is the founder and CEO of Revenue Cycle Solutions, LLC, where he oversees the delivery of comprehensive revenue cycle management services for healthcare private practices. He is also the founder and CEO of Ascend Solutions, LLC, the creator of the Practice Data Solutions, a billing intelligence data platform designed to provide actionable insights and optimize financial performance across medical practices.
So what we want to know is, well, based on our diagnosis mix, based on our payer mix, what our plan of care length should be, what's our actual, compare the two just like we do with ADO and target ADO and get a score, plan of care length score. We do a metric super important for you to have. Again, this is revenue cycle. So revenue cycle doesn't directly understand your cost basis, right? So a certain staff of clinicians, and you have a certain percentage of your revenue that goes to labor. These are cost side metrics. I'm not talking about that today. So a revenue side metric that tells you, at least from a revenue perspective, how things are going. We call this metric gross value of a new patient. So this is a revenue value of a new patient. So if I'm on average paid $100 per visit, and my average number of visits for plan of care is 10, my gross value of a new patient is $1,000. If my gross value of a new patient is dropping, this is why constructing metrics and being able to deconstruct metrics matters, because you have to get down to what is the thing that's changing, that's causing my higher level thing that I keep track of, gross value of a new patient, to actually change positively or negatively. We want to reinforce things that change positively and stop things that change negatively. So revenue per visit and plan of care length drive gross value of a new patient. So we've already talked about both of those as separate metrics. Lots of moving parts that determine those. And so you could kind of start to see how gross value of a new patient, revenue per visit, plan of care length. Over here on plan of care length, we've got diagnosis mix, payer mix. We've got clinical logic. We've got limiters on what payers are allowing us to do on revenue per visit. We've got CPT. We've got units per visit. We've got, again, payer mix over here, visit volumes. So you start breaking this down, it all eventually ends up at raw data. But how you construct raw data points together to build calculations and metrics and analytics and all this is a thing, that you need to do and do well to come up with data points that are really meaningful. A couple other really key metrics that just must have. This is in the relative metrics category. We want to understand our accounts receivables to our production. And we want to always look at patient accounts receivables separate from insurance accounts receivables. So I have an episode that I think has already been out, where I interviewed Debbie and Jean from Health Actions Physical Therapy. Pretty good size practice, 11 offices, doing, I don't want to tell you too many details, or maybe proprietary, but they're a big practice. They generate millions of dollars of charges every month. And at their volumes, think average practice, location, there's no average, could be 500, could be 1,000, but, they're getting close to the 10,000 visit a month range. So you can do the math on that. It's a lot of revenue. It's a lot of charges. Their patient AR as a percentage of production is less than 1%. Their patient AR or their patient payments are over 18% of the revenue, but the AR is less than 1% of production. So bottom line, what that means is they have almost no patient AR. On their scale, to have patient AR under $5,000 and all of it is between 0 and 30 days old, much different kind of outcome than what's normal. So we have relative metrics for patient AR. We want to know our patient AR relative to production. Patient AR relative to your gross charges should be less than 2% of your gross charges. If you're 20%, 30%, we see this all the time. You have a completely broken revenue cycle when it comes to patient responsibility. The whole thing needs to be revamped from the ground up, from patient intake to what they read, to what they sign, to what's communicated, to how what kind of processes you have in place and policies around what you're going to collect at the time of service, credit cards on file, when do you actually charge the credit card, how you use patient statements, all these things tied into the patient responsibility piece. If you're above 2% of your gross charges in patient AR, you have lots of room for improvement. Well, depending upon how far you are from that metric. But these metrics that we create give us a very interesting perspective around what benchmarking really should look like. Same thing goes for your insurance AR. We want to know insurance AR relative to production. We want our insurance AR 80% or so of production or less. Right? We want our total AR less than 100% of our production. So these are relative metrics. We want to be able to calculate based on your current AR, so raw data, patient AR 0 to 30 days, raw data in the AR aging. Divide that number by your current month's visits, and you now know what your time of service shortfall is on collections from patients. Two very common data points put together take on a whole new meaning. So if you have, $30,000 that went into your patient AR 0 to 30, and you have 1,000 visits this month, you are $30 a visit short of what you need to collect in order to have no patient AR. And that's the goal, no patient AR. We have clients that have negative patient AR. We have clients that have huge patient ARs, hundreds of thousands of dollars. Those are interest-free loans to your patients that are probably going to go bad and you're never going to collect on. So understanding AR, patient AR, and insurance AR in the context of production, super important metric to have. Real quick, I'm going to touch on what we do in time-based data. So as I've already said, we track time by task. You need to know to the fraction of a minute how long it takes to do all the different tasks. Normalized for your volume. Is it 1 minute per visit? Is it 10 minutes per visit? Is it 30 minutes per visit? So depending upon the task, you have norms for time by task and how long things should take. And you also have to understand complexity, right? So that we can adjust time expectations based on how much complexity there is within our volume. So we have metrics called objective risks per month, per 100 visits per month. We look at the world in blocks of 100 visits. What do I mean by objective risks? Well, what are the revenue cycle objectives? Collect all your money that the structure allows, collect it fast, days in AR, collect it cost effectively. Anything that negatively impacts one of those three objectives is an objective risk. So we tally all objective risks per 100 visits per month. Our low complexity clients are below 5. Ideally, we'd like 3. Think of that as a percent. So we have complexity that's less than 5% of our volume has complexities in it, which will inflate billing time. Our high complexity clients are anybody who's over 25 to 30 is really high complexity. We have and have had clients that were as high as 50, 60, 70, over 100. Yes, they've broken claims more than once per visit. per claim. So you need to know objective risks per 100 visits per month. Well, how do you know objective risks? It's raw data. You have to count the things that happen that create obstacles to converting potential revenue to cash. We've built an entire data platform to do this. Our billers in 3 to 5 seconds can capture a scenario and tell you what happened. It's mandatory that they use that they convert their experience into data. But we track 280 different things, and I don't have time to get into what they all are, but we attach every scenario to its responsible function. So we have data objective risks per 100 visits per month for patient registration, for credentialing, for authorization management, for verification of benefits, for clinical documentation, for clinical documentation supporting the claim, for on and on and on. You get the point. So we can look at our revenue cycle business in the context of where complexities are being created based on the functions that create complexities. So anyway, you need to collect this data. We've just simplified the process of getting it, from the biller. It would be pretty time consuming for billers to just tally the stuff, put it into a spreadsheet. I'm not saying don't do that. If that's the only option, absolutely do it. But it's not the only option. We've come up with ways to do that. So, understanding your revenue cycle objective risks, breaking them down by function. We do this by location if you have multiple offices, because you know what? Not all front desks that are doing patient registration are actually doing it as well as other front desks. We have clients with 25 offices. We have clients with 15 offices. Maybe 25, 30% of all of your complexities coming from one office. Maybe you've got some offices that are doing a great job. You need to look at where the source of complexity is, quantify it, use that to optimize the processes that are flawed, that are creating the complexities, so that you can fix it. So objective risk per 100 visits per month is a super key metric, as is billing efficiency. So we quantify billing efficiency in terms of production, visits or claims per FTE per month. Obviously, as complexity goes up, that number is going to go down. And perhaps the most important metric of all for your entire revenue cycle business is the efficiency of your billing operation. Well, how do you know the efficiency of your billing operation if you're not creating raw data on time, how long it takes to do things at the task level, aggregating time and rolling it up and calculating it, across multiple different denominators like visits or locations or providers, or so there's lots of ways that you can create different denominators that have different meanings. But we want to know how efficient our billing operation is. And that's why in our model, we hope to collaborate with clients. I say hope because in some cases it works fabulously well. And in other cases, complexity never goes away. It never goes down. And time demands don't go down. And so, the outcome is absolutely dependent on the relationship between billing time demand and billing time supply. If you cannot quantify billing time demand, which means you have to quantify complexity in the volume quantification is simple. Complexity quantification is difficult, but we've built an entire system to do that. You need to understand that time demand side of the equation in order to give it time supply. So now we get into the world of tracking time supply at the task level based on the complexity modeling. And maybe I've already just caused you to glaze over, but if you're in the revenue cycle business, if you're an RCM company or you're a practice doing billing for yourself, you are a revenue cycle company. You just have one client. And this is the way that you really need to operate in today's world to get the best outcomes that you can, so you don't have 40% denial rates and 60% no follow-up rates and leaving money on the table. And ultimately, everyone wants to grow and scale and increase value of their business, but the revenue cycle, how dialed in and optimized, your revenue cycle functions are ultimately determine the scalability of your practice. So you cannot scale a high complexity revenue cycle. It's impossible. You will break. There is a point where beyond which you just can't possibly get. So all this time-based data, time analytics, um, objective risk per 100, breaking this down by responsible function, by location, understanding the individual scenarios. This is where we're creating just tons and tons of useful data on the complexity piece. We're able to normalize and know what benchmarks are for the volume of patient registration errors based on your scale, your size. It's not fair to compare a 500 visit a month practice to a 20,000 visit a month practice. Though the 500 visit a month practice could have more complexity than the 20, chances are to get to 20,000 visits a month, you had to have some reasonably good systems and controls and standards and things in order to get to that scale. So just volume alone is not what's most meaningful. It's volume compared to your production. So what we want are objective risks under 5. A low, a good level is below 10. Between 10 and 20 is kind of medium level complexity. Above 20 is high complexity. If we look at this on a graph, which we've done, we've computed the math around time demand at the task level. We look at the denial management function, the AR function. This is where most of the impact is in complexities. At about 15 per 100 is where the time curve really starts to deflect and it starts to approach. The higher the complexity, the more vertical that time curve goes up. So we can see above 20, above 30, into the 40s and 50s, we're now exponentially increasing time on a per claim basis. And that's very, very problematic because it is almost impossible to just human supply, right? Human capacity with that much variance in the system. Last point I want to make on time-based data and revenue cycle complexity data is that I know I'm talking about something that I've spent years and a lot of money to build a platform. And, if you're already a client, then you have the benefit of us having that data. If you're an RCM company and you're interested in how this might be able to apply to you, reach out to me and we can talk about that. A PT practice with in-house billing and you'd like to really kind of upgrade your biller's ability to create business intelligence for you, obviously reach out. We can talk about that. If you want to just, kind of keep things as they are, you can definitely ask your biller to just create a spreadsheet of issues to log time, even if it's as simple as breaking time down between claim submission, payment posting, AR work, month end, and patient services stuff. That's the minimum breakdown of time that you need. Whether you have one biller and linear process, I've talked about linear process versus parallel process billing in past episodes, but you absolutely need to know the time distributions by the major function. We track it by individual tasks because no one does billing. They do claim submission or they do payment posting. So etc. So they may have a handful of tasks that they log time under, but it's very detailed. So when I say we track time in 50 tasks, no individual person tracks time in 50 tasks. That would be just too onerous and cumbersome to do. But as a company, because we have specialized parallel path billing, we're able to get data across 50 different tasks. So if that's just not an option for you, break it down into the 5 high-level time-based things and then come up with your own way to just document in Excel or a Google sheet or something the kind of issues that billing encounters. You can even do it as just high level as saying, put a one, tally how many are authorization related. Think in terms of revenue cycle functions, right? How many are patient registration related? How many are verification of benefits? You won't have the detail that we have, 280 different things, 3 levels of detail, but you can at least start to understand what baseline normal is for you. So I don't want to leave you with the impression that I'm saying that everyone in the world's got to sign up for our data platform. Obviously, reinventing the wheel on that would be really probably impossible, but it's important enough that you come up with a less robust, less complicated method of capturing time by billing task and then tallying a count of the functions that were responsible for a problem. So at least you have some, baseline data. It's just super important that you have baseline data. The last area that we do a lot of stuff in is in AR audit related data. So we audit on a certain frequency, all the claims that are in AR over 30 days old. So 31 days and up. Audits happen. And the way that we audit is based on condition. So the messier the condition, meaning the more complexity there is, the more challenging it is to create time supplies that match time demand. We tend to see ADO scores above that 105. They might be 120, it might be 130%. So we've established a policy that says based on the ADO score, where it is relative to our target range of 95 to 105%, we're going to establish an audit frequency. So if we're in the sweet spot where this is exactly the outcome that we're after, we audit ARs twice a year. If we're newer with a client or we just really have a problematic practice that's creating all kinds of complexity and time demand and the outcome's not as great, then we're auditing more frequency. We could audit as frequently as once a month. Now, audits take a lot of time, so it's another area that we're looking at doing automations for, and it's probably next. We are very focused right now in creating agentic automations and bots for the biggest time demands, which are in AR statusing and AR denial management. So we'll have complete automation of those for every payer in the United States probably by summer of this year, but we're about 50% of the way there on that right now. So in the meantime, we're still doing manual audits on a prescribed frequency based on condition. But these audits are absolutely gold in terms of the information that they produce, right? So we have, again, very meaningful intelligence level metrics like the AR follow-up score. So we're actually, when we audit AR, we're doing the same thing that we do in an AR audit. We're doing the same thing that billers doing their day-to-day tasks. So when the audit identifies the reason that the claim is unpaid, which could be it's just open and it's in a normal state with the payer. So, you don't want to audit litigation claims at 31 days, right? You might audit them at 6 months or a year. So you have to time your audit also based on payer mix and target ADO expectations. If you have a payer that has a target ADO of 21 days, you don't want to be waiting till 60 days before you go in and start wondering what's going on with open claim statuses. So, but we'll get to a point where we'll adjust that target date based on the payer class. Right now, we're on a standard at 31 days, we're auditing everything that's open, as long as it's not an auto claim that's going to take 60 days or a litigation claim or something like that, that normally takes a lot longer than 30 days to get paid. The vast majority of payer mixes that we see, the average target ADOs for the entire practices, it's not common that they're over 40 days. It's less common they're between 30 and 40, and I would say for the most part, they're in the high 20s. So a 31-day audit schedule makes sense. But what we do is we categorize the reason that the claim is in AR and unpaid. And once we find out what that status is through the audit, we then categorize it by, just like we do in the billing, it's in here because of an authorization problem. It's a verification of benefits problem. It's a patient registration problem. So we are getting a different view of the same data by doing AR audits. And the AR audit is absolutely critical to do. And we probably don't do them often enough. We in a perfect world, we'd be doing these on a strict schedule and never miss. But again, the capacity to do these very time-consuming things it's a problem, and it's why automations are ultimately going to take these things over. But we categorize those in that way that are internal practice revenue cycle functions related. We categorize them in payer-related issues. We use AR related issues again. So follow-up didn't happen, or follow-up is late, or follow-up was actually inadequate. So we're quantifying those things. Is it a payment posting issue? It was paid, it just wasn't posted yet. Is it in there because of a claim submission issue, some kind of batch problem, or problem with the information on the claim that prevented it from being paid? Is it a software issue? Is it an EMR? Is it a PM issue? Is it a clearinghouse issue? Right? So is it a systems issue or a software issue? So we categorize every claim in AR over 30 or at 31 days and up by aging, 31 to 60, 61 to 90, 91 to 120, over 120, just like you would in your AR aging. And we get outputs on these AR audits so that we can know what these audits look like and what the reasons are. So we have a tremendous amount of detail in the audit. We also do this for potential clients. So before we would actually have a high level of interest in working with a practice as a client, we audit their AR because we need to know what kind of complexity condition that really is. So think of this like if we had 4 people standing on each corner of an intersection of 2 roads, right? There's 4 corners, and an accident were to occur in the middle. Each person saw that accident from a different angle. So even though they saw the same accident, they see it from a different context. And what the AR audits allow us to do is understand the complexities and the problems from a little bit different angle. The ongoing time inflation, complexity, data logging from the biller perspective is what's happening right now as I'm trying to complete process. And AR audit is looking back in time and saying, well, this is why these things are still in here. And then we can put audit data together with biller experienced complexity data and get some really interesting understandings about what's going on. Absent having the ability to create the data like we do in our data platform by converting biller time and experience into data, an AR audit is something that anybody can do as long as you have some kind of structure to capture the outcome with. So we've created Google Sheets and all kinds of structures that are not software based in order to do some of these things. And so there's no reason why you couldn't create the same kind of way to create data from AR auditing. So we calculate from the audits, we come up with a metric called claim break rate. We look at the volume of claims in AR, the count, not dollars, but how many claims. Like there's 567 claims in AR over 31 days old. You want to understand that volume relative to your production, your visits, or your claim volume, depending upon if your practice type determines that there's difference between claim counts and visit counts within a month. But you want to understand open claim volume in your AR relative to your scale, to your production. If you're doing 10,000 visits a month and you have 500 claims open in your AR, that's a pretty good metric, right? So we have norms and benchmarks on how many claims should be in AR relative to production. Generally speaking, that does correlate with our complexity data, but we're looking for something less than 30% of your production having claims, open in AR over 30 days old. So again, we're benchmarking all these things, and as years go by, we get more data and we are able to update what things should look like. But the AR audit produces very interesting data. We have clients that are 10% of their visit volume is in open claims in AR, right? So as we get down below 10 here, we're also below 10 typically in the complexity. So our objective risk per 100 visits per month counts correlates with the number of claims that are going to be in AR unpaid. Obviously, because that denial management time becomes majorly inflated, exponentially so, depending upon the level of the complexity. Claim break rates are, we then, once we know what percentage of the visit volume or claims volume is in AR over 30 days old, we then look at, of those claims, what percentage of those claims are in there for internal practice, operational revenue cycle, functional issues like authorizations and VOB and patient registration. So you want to know how your front office operations are creating AR. And so this is analogous to our objective risk per 100, but we then take that rate in the open claims and do simple math. So if you have 14% of your visits are in AR, so the claim count in AR 31 days or older is 14% of production, and 13 or 14% of those are in there because of front office functional issues, then you have a claim break rate around 2%. So the claim break rate is relative to production. So we want to see claim break rates as low as we want to see objective risk per 100 per month in at 2, 3, less than 5%. So if you do an AR audit and your numbers are substantially higher than that, it's a way for you to get a view into how much complexity there is in your entire system, your whole practice, payers and software included. Is this claim break rate can be correlated with complexity levels. And we can help you put those two sides together. So claim break rate, open primary claims over 30 days relative to visits per month, very important metric to know. What percentage of those are in there due to practice, front office, functional things, patient registration, VOB, auth management, et cetera. We also track the clinician contribution to this. So documentation related issues is a separate metric. And then the AR piece is also a very, very telling in terms of how the AR operation is doing, keeping up with the volume of broken claims that need to be fixed. So we count no follow-up, we count late follow-up, we count, needs another follow-up, like it's time now as opposed to it was time a month ago versus no one's ever followed up. So, and then we tally those into a AR follow-up score. We want a number as close to 0 as possible. And again, if you're in linear process billing in a high complexity practice, chances are your AR follow-up scores are going to be very high percentages, 20, 30, 40, 50%. So, and we also are able to count denials in an AR audit, so we can get a denial count and normalize that relative to production so we can get a claim denial rate. There may be other ways through clearinghouse reports and things in order to get that as well. So AR auditing offers a whole nother perspective on complexity, on condition, on quality of the AR, quality and timing and capacity in AR to meet the demands of how many claims there are and the nature of those things. And then all this is broken down by whether they're internal practice front office issues, whether they're payer specific issues, whether they're AR, whether they're posting, whether they're claim submission, whether they're software, whether there are other systems problems. So we can get a very interesting perspective on all the complexities and the sources of complexities by doing an AR audit. So, and that's a standard part of our intake process. If you're a practice out there thinking that all of this data would be helpful for you, this is how we would start. Get an NDA, get logins, we do an AR audit, we grab a bunch of data, and we can tell a very accurate picture just from doing that without even doing the billing. And because I know that you don't have the ability to create this data the way that we do without this platform, without Practice Data Solutions, the PDS platform that Ascend has. You have people that know how to audit claims, and I highly recommend that auditing be part of your revenue cycle process based on some kind of frequency that makes sense for your condition as defined by your ADO score, right? So if you can figure out the target ADO piece based on your payer mix, not that hard to do. You can do it in Excel, you can do it in a Google Sheet. You can then know an ADO score. And if your ADO scores are over 150%, you need to audit now. If they're 100%, you can sit tight, maybe audit twice a year. You do want to make sure that you understand the world according to AR auditing. And so that's another really, really critical must-have metric if you're a revenue cycle business, which I'm assuming you all are because you're listening to this. So, and just in closing, again, we collect a lot of raw data. Then we use raw data to do calculations, and then we use calculations to really create metrics that mean something. And then we're looking at how metrics change over time. to do trending. And then we're looking at how some metrics change over time compared to other metrics to really start to understand. We're getting into analytics and a little bit higher intelligence that's derived from these moving metrics compared to each other. Optimally, ideally, you want to have targets or benchmarks for all of your calculations, metrics, analytics, intelligence level metrics so that you can compare performance against a target. The targets are based on history, based on knowledge, based on knowing what's good, knowing what's not good. You're constantly tracking actual performance against targets so that you can know, how that's going. And since practices are dynamic, there are not static businesses. Payer mixes change, patient mixes change, diagnosis mixes change. Lots of things change normally, even month to month. It's important that you just kind of keep doing this and tracking it over time. This is why the relative metrics is so important, that a change in revenue per visit without understanding, did your payer mix change? You're just shooting darts in the dark. To understand complexity change without understanding payer mix change, you're going to have a hard time really sorting this out. It's not even possible to get into the realm of judging productivity of a biller, to look at that efficiency, that visits per FTE or claims per FTE. You can't even go there without normalizing for systems variances, software inefficiencies, complexities created external to the billing. And again, I'm going to sound very defensive and self-serving with this statement, but 96% of all problems in revenue cycle are not caused by your biller. They're caused external to billing, and the biller has absolutely no control over it. And if your present reality and mindset of understanding of how revenue cycle works is that the first place you look or point your finger at when something's not doing what you want it to do, if that's the biller, you are so off base almost all of the time. 96% of the time, you're going to be wrong. So I don't live in the world of just what I think and accusation. I live in the world of data and what I know. And the right data tells you what you need to know to understand how things really work, how effective they really are, how close you are to being on target to get the outcomes that you really need, and know all the drivers of these things. And ultimately, that's the business of revenue cycle. And the more sophisticated you can be about understanding data and using data, the better life's going to be. You want to decomplicate, you want to reduce complexities. You want to create a condition where this is as simple as it can be so the outcomes are consistent, right? We need to adjust time supply based on time demand to get as close to a constant outcome as we can. And it's the disconnect between time supply and time demand that creates outcomes that are suboptimal. And that's an easy statement to say, but it's a complicated thing to actually know and figure out and put into data. And you're in the revenue cycle business if you depend on third-party payers for your revenue. So it's the game you're in. You need to think this way and ideally, extract the value you can from the systems that you use. We have just found that we have never worked in a software in the PT industry, and we worked in all of them, that even comes close to providing you with the data that you need to create the intelligence you need to really know what's going on. And they may say they have it, but they don't. And AI is not going to do it, because all AI can do as a start is try to understand what a human does and then reproduce it. And if you haven't already extracted the intelligence from the humans doing the process, then your business doesn't have intelligence. You have subject matter experts, and that intelligence that's in their experience and in their head goes right out the door with them when they go take a different job. And so it is super important to convert human experience into data, as well as use systems to create, the individual raw data Lego pieces so you can put them together into really cool stuff. It's just the day that we're in, the time that we're in, the pressures are higher, the complexities are higher, the payers want to pay you less. Yeah, all your costs are going up, and you just have to be a different level operator within the business that you're in, which is revenue cycle. So hopefully you found that interesting. You're interested in how we put all this together and actually make it manageable and digestible. We still need to evolve and be better at converting all of this into actionable intelligence. Here's the 3 things that matter this month. That's what we're kind of working on now and focused on now, is how do we translate all this data and all these moving parts and all of this information into this is what matters right now the most. So ultimately, that's the final value in your data outputs, is leading you down a path of actionable intelligence. What am I going to go fix now? Is my patient AR a bigger problem? Is my complexity the bigger problem? Is my payer mix? Is my marketing the bigger problem? Is my coding, my translation of time into potential revenue my bigger problem? Right? This is like, in a way, it's like golf, right? You got to have all the different, if you ever played golf, you know what I'm talking about. You could be great off the tee. You could be great coming into the green. If your putting is terrible, you're not going to have a good score, right? You hit the ball into the rough off off the tee, you're not going to have a good score. It all has to click. It all has to work together in sync in a way that together all of these moving parts create the outcomes that you need, and the data becomes the true view, the mirror into how things are really working. And if you understand revenue cycle and can align everybody's role and everyone's function around the common revenue cycle objectives, get all the money, get it fast, get it cost effectively, and have data and metrics that show how their role is contributing or not to that outcome. Now you have data that crosses all of these different functions, becomes a unifying single source for understanding how all of this is fitting together and working. Because I almost guarantee you, unless you're at this level of doing things this way, your person doing authorizations has no clue how that affects billing. Maybe they have some idea. If they're a biller, they know. Your physical therapist doing documentation, picking a KX modifier or not on a Medicare patient, has no clue how that affects the biller. But you know who knows? The biller. The biller knows how everyone affects them, because they're affected by every single thing that happens, no matter where it happens from. And so this is why we've just chosen a human approach to problem solving, to convert the biller into business intelligence through data. It all starts with raw data. You have to assemble it. You have to turn it into things that are meaningful, but you need to extract the experience from your people. We are in the process of building out platform to also provide the same kind of time intelligence, time inflation analytics problems. We're going to be applying this to other external to billing admin functions. So the goal ultimately is to have an understanding of complexity as it comes from and affects every single administrative function that occurs. So what are the complexities in getting verification of benefits done, getting authorizations done, getting patient registration accurate? So we're soon to have modules in this view so that even if someone else is doing the billing, you could track how the front office functions are experiencing things that create time inflation and inefficiencies and inaccuracies for them. So anyway, this is a kind of a whole new era, and we're doing things that are innovative. Hopefully you found this helpful, and shortly hereafter in episodes that are coming, as I said, I'm speaking to one of the leading AI experts in the world about how this is going to fit in to all of this. I have an episode coming up with Jennifer Fergalt, who's was the senior vice president of data and analytics for Gannett, which is huge multimedia outlet. USA Today is one of their things. So we're talking multi-billion-dollar operations. She ran data. And so we've got an interview with her coming up probably right after this one about why data really matters and how I'm just not a crazy man. This stuff is important. And we're just going to continue to evolve to try to make it simpler to get great information about how your revenue cycles are working. So again, PT rehab was my life. I look at what we do in terms of revenue cycle and say, you know what, lots of revenue cycles need rehab as well. That's what we're doing in Rehabbing Your Revenue Cycle. Thanks for listening in.